Welcome to the meeting. I guess we should go around and introduce ourselves real quick. I guess everybody knows each other, but I'm Billy Kennedy, County Commissioner for Watauga County.
Hi, I'm Ray Ratliff. I'm Executive Assistant at Smoky Mountain LME-MCO.
Michael Lavender from McDowell County.
I'm Charlie Berry, Safety Performance Specialist Lead at Smoky.
Pat McGinnis, I'm from McDowell County, I'm part of CPAC.
Jeff Eckman, CEO of Mayhead.
Julie Sinclair, Quality and Integrity Operations at Smoky.
Well, thank y'all so much for being here, and we're going to get this started. We've got an agenda for today, and I appreciate y'all putting it together for us. I guess the first thing we need is a motion to approve the agenda for today.
So moved.
All in favor?
Aye.
Thank you, that's approved. And then we need an approval of the minutes from last month's meeting. Do I have a motion for that?
I'll make a motion to approve the minutes.
Do we have a second?
Second.
All right, all in favor?
Aye.
All right, thank you. We didn't need any changes on those, did we? I think this sounded pretty good. I do want y'all to bear with me. I'm still trying to get up to speed on this, and hopefully I'll be a good help instead of a problem. So I guess the first thing, I'm lost already.
Too many papers here.
If you want, I can
There it
clarify.
is. I got it. Okay.
The big clip, if you take that, just take the big clip off. Our meeting is in the very back of that. That's the whole packet for our meeting.
It's exactly the same as what I handed out last time,
No, this is the agenda and everything
but
for the
the
last meeting.
one where the quality improvement program
Okay.
evaluation is
And-
not different.
Yes, but that's not in our packet. That's in the
Board
meeting of the
packet.
board packet.
Right.
Yes, and sort of in the.
So we need to pull that out. Is that
That was this what you looked at?
right?
Is that
Yeah, I
when
want
we
to look at
brought them
mine.
home?
Yes, and this is the program description. I wonder which one we need to start with, because I guess we need to approve the program evaluation description, but I didn't know if we wanted to go through them individually.
Okay, well, first I wanted to tell you that Charlie Berry is here because he's smarter than I am. He writes this. And yes, we do need to, the board, this committee, if there are changes, we would appreciate your recommending to the board proper approval of this plan.
Assuming, or with changes if we
Yes.
have any changes today.
Right.
Okay.
And this will be new because in the past, there hasn't been this committee and it's gone on a consent agenda. So this will be one of the very first times that board members have reviewed this in detail. So we really look forward to hearing from you. And then when you have the board meeting, if you would just recommend approval, then that would document that for our oversight agencies that the board has seen this, and we'll have these minutes with your
Okay.
questions. But Charlie can answer questions, and then I don't know, Mr. Chair, if you want to give this 45 minutes and then go over the monthly data as usual, or if there are no questions on the monthly data, it's, we can.
Yeah, I guess we should see how long it takes to go through this, but we need to keep an eye on the time because we do have the other meeting afterwards.
I can let you know when it's quarter on.
Well, that'd be great, thanks. Hopefully y'all have had a chance to look over this, and I just highlighted and made some notes as I went through it, and I didn't know if we should just go through it or just kind of each take a turn. I don't know what's the best way to do that. And I didn't know whether you wanted typos pointed out or not.
Oh, yes.
I didn't find many.
Yes. I think it's probably easier just to go through page by page. Is that okay with the committee? The one thing I noticed, Charlie, is we need page numbers.
Okay. We've got that on the program description, but you're right, we do.
On this,
We have it on some, but not all.
Not
Right.
on the evaluation, you're right, I didn't notice that, okay. So do we
and
want
this
to
is
start with the
actually the
evaluation or the
evaluation
program
and executive
description?
summary. I don't
Because
know,
these are
which
the two-
is it easier to come first?
I think the program description is probably the best to start.
Okay.
Which one?
The program description,
So that's this larger one.
right. And it was very helpful to me. Like I said, I'm not trained in the field of mental health. I've been on this board before, but I'm trying to get back up to speed. So I guess I'll start with a couple things. The Quality Improvement Committee is Smoky employees, and then y'all recommend to us changes that we recommend to the board. Is that how it would work?
We have consumers and providers on the Quality Improvement Committee too.
Okay. So y'all get constant feedback, and that's where a lot of these issues have been brought up, and then y'all try to put in a procedure to make them better. Now, I guess the chief medical officer is in your committee and chairs your committee, and so that goes on all the time. We don't see him at this committee then, do we?
No,
Okay.
you can if you want to invite him.
If there's, if somebody has specific questions that we need answered, but otherwise I don't see any. And we get this quarterly, we go over. One thing was kind of a question, the Alpha MCS system, is that the new reporting? I'm on page 5, Health Information System and other system-wide information services.
No, that's our MCO software, and I think you're thinking of NC Tracks, the state system.
No, I'm this.
Right, the Alpha is our system now.
Okay, and I was just wondering, is it shared or is it merging with other hospitals and other systems, or is it just in-house? I mean, because it talks in here about bringing in information from hospitals and other stuff. I was just wondering how it's coordinated.
We don't have a health information exchange yet, that merged thing that you're talking about. It is one of our visions, but how we get that data in, that data is produced by the state, and the state uploads it to an FTP site every month. They upload professional, institutional, and pharmacy data, and we pull it into our system, and we put it in our data warehouse, and it can be used by Alpha and other reporting mechanisms that we have.
And the providers have access to that Alpha.
Providers
some
have
access.
access to that Alpha, but they would not have access to this other data because it's protected health information.
Okay. So there's a confidentiality issue there, and then there's a so that this is a month delay on that Alpha. I mean, you're getting data from the state, and then a month later it comes into our system at the earliest because they compile it and then you work on it. So
It's raw claims data, so I'm trying to think. It usually comes in about mid-month
okay.
for the previous month.
But I noticed in here somewhere, and like I say, if I'm getting off, that we're looking to have more current, immediate data from hospitals and stuff. Is that a different issue?
Right, real-time data.
Real-time data, that's the word I'm looking for, thanks. To track things, is that important, or do you get enough from that month down?
It's very important because of our projects trying to reduce inpatient and emergency department visits, and length of stay in emergency departments is where it's the most important. But it's important in inpatient so that we can intervene and do discharge planning in the event that the hospital hasn't notified us, then we are aware of it through other means. So the real data is very important.
Yeah. And that's some hospitals are providing it, but not all of them. We don't have all the hospitals providing this in the system yet.
Correct.
We're a long way away from a fully integrated health information exchange. That's badly needed nationally, locally, regionally. You would think that healthcare would be the best at it, but we're actually banks, real estate agencies, certainly retail vendors, much further ahead.
And is that the privacy issue, you think, some of that, or funding?
Well, it's very complicated. I mean, it has to do with proprietary EHRs. It has to do with the HIPAA rules. There are many reasons that have kept them from interacting. In fact, the point is, we have to work with what we have. So these claims data is not bad if you know what's been billed for. You can extrapolate some information about that.
Right.
But still.
But so this is something that Smokey's working towards with the providers and the hospitals that I mean, I saw like 2 or 3 hospitals out there.
Right, there's some complications, and one of the complications is that the hospital data, the real-time data that comes to us called an admission discharge transfer report, that comes through CCNC, and not every hospital belongs to CCNC. So, because there's a fee for it. And even if they did, with the Senate wants to do away with CCNC.
I saw that, yeah.
So that's a kind of unsure area.
And that's kind of the clearinghouse right now for some of these hospitals.
Yes.
I mean, the information goes through there, so that would make it harder for us to get.
But now we are getting the institutional data, we're getting it later, but not real time. The other big hole is in the emergency department. We don't pay claims for persons who are uninsured and underinsured. That's probably 50 to 60% of the population that seek behavioral health services in the emergency department are uninsured or underinsured. We have no data on them at all.
No, the hospitals are picking up that cost
Yes.
right now.
Yeah.
So it seems like
it.
So
they
unless the
want that
hospitals
data.
give it to us themselves, there's no other way of us getting it.
So would we reimburse any of that if they gave us that data? I mean, is that something that falls under our, I know we cover some uninsured, don't we?
We cover
And
uninsured individuals, there's no way we could afford that. We get the state funding is 10% of our budget at best, probably more like 9. And so while we cover all behavioral health Medicaid in the emergency department, it would be impossible for us to cover. Yeah.
So that's a gap that the hospitals are bearing right now.
Yes.
And it seems like they'd be pushing to
Yeah.
get some of that back from that Medicaid or the mental health stuff.
Yeah.
I have a question on page 7.
Yeah, let's go ahead.
The satisfaction surveys, the perception of care survey.
Uh-huh.
A couple of things. This doesn't seem to incorporate what we were discussing last time about having a broader sample of providers. The other thing that I would add is, it's not necessarily pertinent to this document, but just as an aside, my daughter is in counseling and bed management with Caring for Children over in East Asheville. We happened to get surveyed this past week, and one of the things I noticed and had a question, the survey itself, and I didn't note everything that I might have done differently on it, but one thing that really did stand out that I asked a question about is that you're surveying an organization, but in my daughter's case, she sees a counselor for therapy, and she sees a different person for med management. And my rating of those would be different. And I had to kind of combine those for it would seem to me that if we wanted to have a better understanding of not just the overall picture, but where an agency might be falling short, is that if we had some type of separate questioning so that they could differentiate between, because for example, I like her therapist a lot, not just from personal status, I think she's doing a great job. I'm not particularly happy with the management person. It's just, I don't know that it needs to go anything like this, but it might be something for us to consider for the future. But I would particularly like to see us talk about larger sample sizes.
Yeah, are they both from the same provider? Or they're different providers?
Carrier Children is the main provider,
Okay.
but.
And the survey came from them?
The survey
is
from the state, actually.
Okay.
Smokey has to administer this, yes.
Oh,
We
okay.
administer it, but it's prescribed
Gotcha.
to us by the state.
I was thinking that the provider satisfaction and the perception of care were two different.
They are,
But,
they're both
but they're both
prescribed.
prescribed. Well, it might be good for us to pass that along to the state. I mean, because it's hard to say that you're getting good data on the organization as a whole if you can't differentiate what in that, you know, you could be really unhappy with one part of the organization,
Right.
but every other part be totally happy. And if you can't differentiate that, then you might, in your mind, say, well, I'm going to rate it the lowest. I don't know, you see what I'm saying?
Yes, I do.
Yeah.
Which you should.
But you'd have to change that at the state level, because we don't, or can you
Yes.
add questions to this survey?
We can add questions, but the ones that the state prescribes, we can't change because they're actually based on the national survey. I don't know.
It's not PCR.
I don't know what PCR is.
That's a national term.
I think it's SAMHSA.
Yeah.
Have to prescribe some questions.
That's the state. But you know, I mean, the thing is, you're really right. I mean, what we're doing in terms of these are actually some things that are prescribed in medicine among medical providers, but what they require is we know now that we need at least 50 surveys per provider per quarter to actually have a good sample size. And one of the things that Smokey could consider, you know, there's a lot of data here, but what you really want is the data that you're prepared to act upon.
Right.
So you know, one of the things if we ever get into, you know, managed Medicaid and integrated care, you know, one of the things we may want to do is we may want to do some pilot projects where we use a nationally validated survey like SAMHSA or PCR or somebody else that then can look at those surveys across a national standard. Because really, even if you get surveys, you can't really interpret unless you know what the mean is. You know what the mean is, what the 90th percentile is, what the 30th percentile is, and you know we should do that at some point. But you could never do it with an organization the size of Smokey without costing an arm and leg. I mean, it's really expensive to do these, and they're all validated. But the really good ones are actually phone surveys, and every single call is actually recorded, and then the providers have the opportunity to listen back to them.
I would like to see consumers have the option if they're not, you know, if it's survey time, surveys are being sent out, not everybody's gonna get one. If they go to the provider, I'd like to see something posted on the window that says, survey time, if you did not get one and you want one, call this number.
That's a good idea, Pat.
Because you're feeling that people don't realize the surveys are going on.
Well, yeah, definitely, and you know.
There's an annual one, and then there's some that are quarterly. Didn't I see this somewhere? Is that what we review? These
Measures,
two are each annual.
Your opportunity to give feedback, if you've not been given one, not been contacted, call this number and we'll send you one.
But the way they were doing it at Care for Children is the Smokey staff were in a room, but as people came through for appointments, they said, you know, that you have an opportunity to do this if you're willing to take the time to do it. So if you happen not to have an appointment within the window of time that you're not getting surveyed, although, you know, again, it's a question of numbers and
An adult mental health consumer social reviews, and let's say you do have an issue, and they know you have an issue, you're not gonna be handed a survey for the most part. Unless it's random and it comes in the mail.
Yeah, I mean, a validated survey does just
right.
that. So if you just took people who were unhappy, or just took people that were happy, you wouldn't have a valid survey.
Right.
So what you're talking about is sort of a complaint, sort of a complaint box or something like that. Those are helpful too, but they're not.
Well, no, I think, Pat, I think that's why we came out and distributed the surveys this time. Before, we've allowed the providers just to hand them out. And we wanted to make sure that that the opportunity came to everyone who walked through the door, not just people that provided or selected to take the survey.
And that's
It's
true.
still not random.
Yeah.
Because, you're
It's a
there
convenience
one,
sample.
yes, yes it is.
We've had sort of an interesting week or two in my household. John had surgery 3 weeks ago, and somebody is coming into our house now. And they came last week, and it's like, and we will be here the first Wednesday of every month. We expect y'all to be home, and and it wasn't about accommodating us or working with us. I can't wait to get a survey, but I felt so violated. And it's been a long time since anybody's been in the house, a case manager or anybody to see me. But it was his health. But I felt so violated because they wanted to go through the house. They want to go to the bedroom. And it's all about oxygen. And we're not used to having strangers in our house, much less having strangers in our bedroom and acting like they're entitled, just to go traipsing through the house, and then they go to the kitchen and slap something on the refrigerator, and I'm like, man, I can't. This just doesn't feel comfortable to me. And it wasn't even about my health, but it really made me stop and think what our consumers, when it is about their health and people coming in that they don't know, must feel.
So you think they need to be more sensitive and more aware of this situation they're coming in?
I'm going to be frankly honest. I've been trying over the past few years to be less of a bee, but I can be a really good bee when I want to be.
It is frustrating.
And it
when
brought it out in me. Let me tell you, I said, well, let me tell you about the Americans with Disabilities Act and reasonable accommodations and the Panic Advisory Council and Disability Rights North Carolina, and we will work together,
They were surprised, weren't they?
But not everybody
Right.
knows all these things. We will try to be here, but there will be times when the first Wednesday of the month we may not be. And what about reasonable accommodations? And and I talked to Brian Brian Shupin. He says, were you given any choice of providers? And I'm like, no. And then I went to the dentist. And somebody else came from respiratory therapy. Didn't ask him about his breathing or nothing. Want to go to the bedroom? Well, no, can we sell you some water to hang on you a while? I'm not comfortable.
But these
with
were
this
medical issues.
This came out of the federal
Right,
system
right.
from the VA.
But not mental health.
But now let me tell you about that. He had a roommate that was in there for medical reasons that was planning to commit suicide. And so the hospital knew it. They came in the room and told him, well, it will be 28 days before we can get anybody to see you about mental health. Sent the man home. On the way home after John spends 4 days in the hospital on the Old Fort Mountain, he says, the man in the bed next to me is planning on going home and committing suicide. I told his family, I hope they got the guns out of the house. I hope they listened to me. So we're not doing as bad as we could be. I'm like, well, doesn't the federal system have urgent, emergent, and routine care? And wouldn't this be kind of urgent or emergent? So, I don't know. I'm not going to be the right person to be at this meeting today.
No, stick around. We need to hear it. Well, let's move on to the smoky stuff. Keep going on through this. Care coordinators document that. And I was wondering if this, on page 10, smoky employees receive an orientation regarding smoky's privacy and security. Is that part of the board orientation too?
Yes.
Yeah, we do it for every new employee.
And Tracy does it for the board.
Yeah, and I think I had one, I guess the last time I was on the board. I came on right after retreat,
Okay.
so I missed that one this time. Okay. The Human Rights Committee, on page 12, that's within Smoky?
It's actually, Smoky has a person that staffs it, and Smoky has a person that reports out on grievances and incidents, but it is all stakeholders, and it's self-governed. Did I describe that properly?
The Brian Stupin is our staff liaison.
Okay. And there, I see there are 20 of the 27 positions filled. Are we trying to get those other 7 filled? And so those are consumers, not
Consumers and
providers.
family members.
And family members, okay.
Are there providers on it?
Stakeholders.
But not providers.
No, not providers.
When I get done being the PAMI chair, which will probably happen in December, that's probably a committee I want back on.
Well, good, we have 7 slots.
Just a couple of questions for me. Access care, I guess that's one of the Medicaid primary cares in Watauga. I've noticed it's the one, I'm not familiar with that, but.
It's a CCNC?
CC in the Far West.
Okay. Let's see, I'm moving right along. If anybody has any questions, I'm just kind of looking at things. Here's a,
So the reason you're not familiar with it, just let me say, it's kind of like an organization and the different practices belong. So you might not be aware of the organization that binds them together. You would be just aware of the name of the practices.
okay.
Wouldn't that be?
That's probably reasonable.
I think this is a typo on page 13, scare care coordination, allocation scare care. Page 13, next to bottom line, critical tool to allocate scare care coordination.
Julie, if you can keep up with the typos, that'll help me.
Oh, you don't need to worry about the typos.
What is
I'll do it
scare care?
Friday.
Excuse me?
It's nothing, cross out.
It's just a typo. It should have been care. Just it doesn't. Scare doesn't belong there at all.
No, it doesn't.
I was wondering on the analytic tools on page 14. It says the decision process is data driven, and how do we get client input into that data? Is that come in through the surveys or? Does that make, is this line right here?
Right, I was looking at the heading.
So I was just wondering if the clients are getting, I mean, I know the data we get results, but are they getting, is that input from our clients going into
The data-driven piece that this, that would go, be pertinent to this would be outcomes measures.
Mhm.
So those are based on consumer input.
Well, I'll have a question. You're talking about data-driven and output and outcomes. And it's probably not in here anywhere, but I was involved in a conversation last week that said North Carolina now, since the passage of the ADA, there are 3 times as many consumers now have guardians as had before the passage of the ADA, and that guardians are now becoming the new case managers. Can we get some data on that? And that part of the problem is Brighton Hospital, and they don't want to release anybody into the community these days without a guardian. But that these folks are really not at the level of needing a guardian. That they need a little help, but that they don't need somebody being in charge of their life. They need a little help, but the new trend is for them to come out of the hospital with a guardian, and that not only is it happening here, it's happening in schools when people are about to turn into 18. It's happening all over the state. It's particularly happening according to a conversation I had with some people in our part of the state. So is any data being looked at or kept or even considered on this?
Not by smoking.
Wouldn't we want to know some of this?
I've written it down.
And is that a state decision there, I guess? And do you think that's coming, wondering where that drive is coming from?
No,
The
it's
drive would come from a doctor who decides to declare somebody incompetent to make their own decisions.
But you say there's a
Or-
rise, if something has changed.
if
you're
it's in a
thinking.
hospital, but
Well-
if it's in the community, anybody can make that request, but it requires a physician's evaluation.
And ultimately, it is a court decision.
Right.
Adjudicated in court.
Well, it's usually handled by a magistrate, and from what I've understood from the
No, it's
consumers
court.
I've talked to, they don't have much of a voice, and they're not paid very much attention to during these processes.
And would this
It's
be
court.
like the
Medical.
IMC, like so if they rated it 10 or something, somebody, I mean, it,
Before they're discharged,
Okay.
is what I hear Pat
Right,
saying,
but that's
especially in the
a big,
state
big problem.
facilities.
Also, I've heard it's happening in the high schools when children are about to turn 18,
Right,
that the
right.
high school counselors are saying, well, you won't be able to come to their IEP meetings anymore after this unless you go do this. And that a lot of things like this are happening that are really violating the rights of folks that have done nothing to have their rights violated. They're not at the level they need their rights violated at. And, you know, the ADA, when it was passed 20-something years ago, is supposed to give people more freedom. There's something wrong when 25 years or whatever after the ADA is passed, we got 3 times as many people having less freedom instead of more freedom to live in our communities and our societies.
so we'll look into that a little bit and see if we can get any more data on that. Moving right along, I guess peer-reviewed vendors, I should know what that is, but it's just other vendors that, I mean, I know a peer review on doctors and other
So
stuff.
it's not typical peer review. When we make decisions regarding authorization of a service, if it's denied, it has to be denied at the highest level. And so the peer reviewer is the one who reviews the decision-making process and all of the supporting documentation that has gone in to make the medical necessity determination, and then they either uphold or overturn the clinician's decision.
So that's a position in Smoky that makes
It's
that
actually, yes, a physician in Smoky makes the decision. We do have peer reviewers in our organization. They are PhD level psychologists and our 2 psychiatrists. But if we need decisions made by a certain time and our resources are low, we have a vendor that knows the service definitions in our state, and we can refer it out to a physician with that vendor, and they can make the determination.
Okay, thanks. I noticed that the providers were not real happy with us, and I wonder if some of that is not happy with the policies or with the reimbursements. I know there are a lot of people frustrated with what goes on in I get my frustration sometimes with the legislature, but I'm wondering if the providers' dissatisfaction came from any of that. I'm kind of jumping ahead here, I guess, but.
So,
Well, I had it there,
A
attendance.
lot of investigations going on, that it looked to me like ongoing or not completed or.
the providers who have been long-term providers in the Medicaid system are used to having any willing and able qualified provider being able to participate in the system. And that did not have as tight an oversight as managed care. So I think that sometimes it's a little kickback with that. We have a closed network, we have a way of selecting providers, and
So we try not to duplicate.
right, and I think that on our survey, in all fairness to providers, some of our credentialing processes take longer than I think they should, Julie's opinion. Sometimes we've worked really hard based on the provider survey because it said that we weren't getting answers to providers when they called. So we've worked really hard to streamline communications and provide employees with answers so that you can get an answer the first time you call on the phone. So that was valuable feedback for us.
And this focused monitoring, I guess that's what I picked up on, and they come to that and it helps them.
Focused monitoring Okay, routine monitoring is what we have to do every year regardless. Focus monitoring is our going out. People don't like focus monitoring or investigations because it's going out above and beyond the routine monitoring. But you go out and do focus monitoring when there's been a problem, like a trend of grievances about a specific provider, something like that.
And then you do that with the provider. I mean, y'all go in and do it, but the provider's participation will be expected, it says.
Right, because we might need to look at records, we might need to interview staff.
Okay. All right. Anything else on the program description?
Can I just ask, on page 15, clinical practice guidelines, are those state standards, are they developed locally? It looks to me like they're developed locally.
They are not developed locally, but collected locally. They come from national standards and state clinical coverage policy. We don't actually create them.
Okay, yeah, that's, okay. How many are there? Clinical practice guidelines?
Lots. You can go on our website and see them.
Is that right?
When folks are getting out of jails and prisons with mental illness, are they referred to Smoky? Or somebody in our care? Are they referred, one of my concerns and questions was, wonder if the people getting out of jails and prison with mental illness are coming out with more or less supports than the people coming out of the state hospitals. And are the people in jails and prisons that are coming out, are they coming out with guardians and appointments and this, that, and the other, or is it just the people coming out of the state hospitals that have mental illness and substance abuse disorders and this, that, and the other that are, all these extra precautions are being taken?
I doubt that people who go into a jail or a prison come out with a guardian if they did not go in with a guardian. Some jails, we have relationships, better relationships with some jails over others. We have better relationships with some prisons over others. I would say we have better relationships with our local law enforcement community than the prison system. There is a there's a data set that we have access to that we can check daily to see who has gone into or come out of jail. And we can look them up in our system to see if they have a provider. And if it's somebody going into jail, we can notify the provider that the individual has gone into jail. And if it's somebody coming out of jail that has a provider, we can notify them of that.
Is this something y'all do regularly, routinely, or occasionally, or?
We, our community collaboration business specialist looks at that list daily, yes. And you have to look at it daily because it's only a snapshot in time. So it doesn't tell you who's in jail, it just tells you who was
In or out?
put in or to come out.
The day of.
So the person coming out of jail or prison really might be a whole lot more of a threat and a whole lot worse shape than the person coming out of a hospital. But the person coming out of a hospital may be coming out with more restrictions on their life.
But, and it may just depend whether they've got Medicaid or uninsured. I mean, if they're underinsured or uninsured, nobody's gonna pick them up at all.
Well,
Unless
I think
it's,
you're talking about the
I'm talking about
guardianship.
guardianship. But if they
we're gonna
max
find
out
out.
their sins,
I'm going to,
find something about that.
I'm going to see if we can easily access the data. I'm not going to promise to bring back the data because if Smokey does not think that it's a priority, because anytime you have to develop a report to get data, it's lots and lots of hours of time. But I'll have to look and see in our system if there's a way of seeing who has guardians. But I'm also going to talk to our Broughton Hospital liaison and see if they have the same impression as do you of what's going on.
Thank you, that sounds good. So should we go on and do the program evaluation?
Did you want to look on the program description, the quality improvement projects go with the program description?
Really quick about project, we have 5 projects that are reported out here.
So do we want to go through those first then? Go on next, go through those 5 projects and see if anybody had any specific questions about those?
So I'm just gonna, the call center project, I believe you all are quite familiar with this because we talk about it every
Yeah.
month because it's on our corrective action plan, so I think we can probably.
Yeah, there was a little thing about the rings, the number of rings, and that 5-6 seconds, because on a cell phone, it doesn't ring the first time. You hear it on your phone, so hopefully they're picking up on that, because that's several seconds, and then cell phones start charging the minute you dial instead of, so it looked like y'all had figured some of that out there.
Yes.
Could you point out the project updates that you feel like are the significant ones, the ones that stand out, or anything within any of these reports that have the most pertinence?
Well, I can give you a quick summary. Y'all are familiar with the management call routine, definite improvement. And we're looking at, we're just monitoring now to see if that improvement is sustained.
And I don't think the NC TOPS one, I mean, that's something we're measured on. I don't think it's significant as far as consumer or provider. It's like an academic exercise.
And I was wondering if
the
providers
other
supported
three-
that NC TOPS. Are the providers supporting that?
Actually, the providers are not completing them, which has created a corrective action plan for smoking, because theoretically we are supposed to be able to control our providers better.
That will reduce your satisfaction rate if you control them more.
Hi, Duncan.
So the other three projects are, I think, have a big impact. Don't they?
Yes, the readability of clinical reasons that I refer to as a slam dunk. We went from 0 to 98% and nothing flat. We solved that problem in a hurry. Assessment, treatment of mental health disorders.
Well, wait, in this one, I just want to point out the readability of clinical reasons. I think I refer to it every time I point out the trend in our appeal levels going down. When you can write an explanation that somebody understands and offer alternatives, then
Right.
you're not going to have as much disagreement with your decision. Sorry.
And the assessment and treatment of mental health disorders and intervention beneficiaries is a new project. We have established a baseline that will be remeasured again in a year. Essentially what we're looking at there is individuals who are interventions recipients who show symptoms of mental health symptoms, and looking to see whether or not they have had a mental health assessment and or mental health treatment. And we find that there's a significant need for improvement in that area.
And that's on, or they're not page numbers, so
Right.
I see where it is, but what does it, where do you make those conclusions? Where in this?
Let's see.
Which one are we on?
This is a
Treatment.
recipients. Is this right here?
Assessment and treatment.
Okay, so
Should be
that we took everyone who's an innovations participant, which that's about 1,600 people, and they did a random sample, and truly random, and looked at the records, and looked in the notes and the records to see if there was any mention of symptomology of mental illness or mental health issues, and then they looked to see if that person had had an assessment for those issues, and the project is, the improvement would be for anyone who displays symptoms to have had an assessment. So we're in the early stages of this one.
That's right. And in our baseline, what we found is only 20% of them had received an assessment. But significantly more have received some sort of treatment, something in the neighborhood of 75%, I believe, have received some sort of treatment.
And this is really important because across the board in our most recent survey for our gaps analysis, in every stakeholder group, the a gap of services for co-occurring illness was identified as a need. So,
And that's multiple
diagnosis
diagnosis
so
with a
like-
single paid client.
Mhm.
Okay.
So yes, so if you don't have somebody who's used to treating co-occurring disorders, then they're just gonna diagnose everything, like if I'm an MH provider, I might just diagnose everything as MH and not look to IDD or substance use or even medical illness. And I've had diabetic patients that have more mental health symptoms than physical symptoms.
So how are we training people in more fields or bringing in, how do you answer that,
These are,
let's see, how do we answer it?
Another thing, they're gonna put them where the money's at, to get reimbursed, in my thinking.
so these are the measures, on the QIP, they have the interventions, right? I don't know what those are.
Yeah, project strategies, we're doing trainings, identifying best practices on assessment, identifying expectations for assessment, strategy for network development, and communicating expectations to the network.
So we're working on it. Okay. So the only other one is that risk support needs assessment?
That's right. And this one has to do with, there's two documents, risk support needs assessment and individual service plan. Have to do with making sure that there's a medication section in the risk support needs assessment. And there's a diagnosis in the individualized service plan. And so we need to ensure that the diagnosis in the individualized service plan matches the medication or the diagnosis as would be reflected by the medication in the risk support needs assessment. And this has been in progress for quite some time. And we are seeing a trend towards improvement, but there's been considerable ups and downs. And it appears that we may be getting close to as much improvement as we're going to be able to get. Given it's a situation in which, as I understand it, the care coordinator has to essentially come up with a diagnosis based on the medications. And of course, a given medication may be due to many different diagnoses. And so it may be that we simply cannot expect a whole lot more improvement.
So instead of
Why wouldn't they go to the prescribing provider?
That's a good question. I think it's just the nature of the process.
Well, we're gonna get down the road on integrated care and.
There you go. There you go.
Yes, we will.
And what kind of sampling do we have? Is there
It's 100%.
and is that from the clients or from the providers?
So clients, all the innovations consumers. It's 100% sample, right? So all 1,600?
For RSNA, no, actually, we're looking at a 95% confidence interval.
Oh, okay.
So, however that comes out each month.
Oh, okay.
And do you think they feel comfortable being negative in that survey when they're receiving services?
It's not, it's the care coordinators who are being honest and our own QI staff looking at it that are looking. That person is taking, let's say, Prilosec. Do they have a diagnosis that goes with Prilosec? Because
I agree with you. Solution really is anywhere to care. When we get there.
Is that measured up against both physical and mental health problems? And you could never get to 100% on that.
No, correct.
Off-label uses, not listed diagnoses, many things. You'd never get to 100%.
Okay. So, do we want to go into the program evaluation?
Sure.
Sure, Gordon. We got through those, didn't we? And, on page 2, I guess, Oh, there's no page on the second page. The crisis intervention training for area law enforcement officers. I think we need to be looking at that for jails as well. You know, there's Miami-Dade and LA being the biggest mental health centers in the country, jail being the biggest mental health centers in the United States now. I know that our jailers don't have to make the initial evaluation, you know, like the officers do, or the hospital does. But once they're in, and I saw that we're responsible for physical or psychological damage, I think it's important that these jailers, and if we could expand that CIT training to some of our local jails that are having regular mental health issues, and especially to avoid suicide and other stuff like that.
I'm used to. I was thinking, because we had this conversation several times in McDowell County over the years. Technically, Smokey isn't, even though we've tried to help, we're not technically responsible for their mental health care while they're in jails, right?
Correct, but this CIT training,
Right.
it's crisis intervention training for
Right,
law
let's talk about
enforcement.
that.
So, I think the recommendation is that, I mean, we aren't technically responsible for individuals in jail. We aren't technically responsible for people who get pulled over on the side of the road, but if they have a mental illness, if the law enforcement officer has CIT, then they're better equipped to deal with them. And I actually,
Understand what you're,
why don't we train the jailers?
okay.
And even though they're not actually diagnosing, they're going to be dealing with this person, they're going to be loading them up, they're going to be transporting them.
I think it's a good idea. I don't know if
Oh,
we'll
I
do
don't
it.
disagree.
Yeah.
I just wanted to make sure I understood what you're
I
saying.
know that one of our captains who, a couple years ago, I spoke to him, he was against the program again, and he did the CIT, and he's a believer now. So just because there's some resistance to it, I do think it helps all of our, they're dealing with mental health issues every day in the law enforcement. And that's one thing they brought up to me was who's reimbursing all the transportation for the mental health patients? And there's no real reimbursement. It's individual counties, I guess, because Smokey doesn't reimburse transportation, do we?
No, Medicaid doesn't reimburse transportation. Smokey does some, we do, with our state money. But transportation is one of the largest barriers to services across the state. I don't know about nation, but I would imagine in the more rural states that it's a very common barrier.
And we mentioned that last meeting too, so we didn't come up with a solution, but we need to be keeping aware of that.
It is
I don't know about the
actually
other
in
regions.
our strategic plan, one of our priorities, to explore transportation options and to, if the Senate doesn't take all our fund balance, to reserve some funding for a pilot program for transportation.
The one here, is that the one? That one's already going on, isn't it?
No, that's the G4.
Yeah, that's finding that kind of medicated money, so. I jumped around to
There's
the
a-
program you had going here with Buncombe and Mayhack and Smokey.
Oh, yeah, no, it's not that.
Okay.
You
Well, I know
know,
there- I'm sorry.
I think CIT is a good training. I went to one several years ago myself. I think we need to go a step further. We might need to come up with, I don't know, for lack of a better word, PAT, police avoidance training. We need to teach consumers when there's a situation to walk away and not get involved with the police and law enforcement to begin with, and we're not teaching them that. I mean, that's sad. We're doing peer support stuff, but we need to add that to it. We need to teach them to walk away, because once they get involved, it's a whole lot easier, and statistics show they're more likely to end up eventually in jails and prisons after they've had that first or second encounter with law enforcement.
Well, if we could. And I know that Daymark, if our sheriff's calling for Daymark, they're supposed to send somebody out, but they're saying they're not always available. But that would be under Smokey's reimbursement if this person is Medicaid and
Not if they're in jail.
So that program isn't really funded for the Daymark staff to go intervene in.
Right,
No,
I used to do a
cases.
program like that, and we just did it because it was part of our mission and not part of our funding.
So that could be something we could look at with some of our disposable income, that 1%.
They might be reimbursed with state funds. I think there are some state funds, because but I'm not, I couldn't work.
Yeah. Just curious, because that the sheriff's department are dealing with mental health all the time.
Oh, yes.
But currently, the funding isn't for that, for the providers to go to the jails.
Right.
It is, and sometimes providers do when they can, but it's a very expensive endeavor with risk and absolutely no reimbursement.
So I guess on the CIT, you're hoping these officers who've been through the training will have at least a basic knowledge to be able to send them to the hospital instead of taking them to jail or something, making that decision. Okay. Moving right along, ongoing QI activities need to address. Rapid readmissions, that one we're just working on still.
That's a new project.
And I guess the lack of agreement between medication and risk support needs, does that get it to the discussion we were talking about earlier?
Yes.
About the medication, appropriate medication? And how do you, and on the last line on the next page, below above multiple areas, maximizing the effective use of best clinical, I mean, that's just, maximizing is a pretty broad term, there's not specific actions going on there.
I see it. I'm
What this is to highlight, that the details are in the following 40-page document. If you dig into the 40-page document, you'll find the details.
Which is this one here.
The actual quality improvement program
Evaluation, yeah. Okay.
Yeah.
But it really is to develop a clinical plan for our 23 counties based on prevalence that would best meet the needs. That's what our clinical plan is. It goes along with our network development plan.
So you look at local issues and state issues and compare that to national trends too as well?
Mostly local and state, and develop a clinical plan. And we're really trying to increase the use of best, promising, and evidence-based practices.
Moving on to multiple areas, need for increased participation in free trainings and community education events. Do we have any plan of action to get people? I think that will help to overcome the stigma.
I think Smokey's doing a good job already at some of that. I've been at several trainings. I refer people in the community, including my daughter-in-law. We went to a Darkness to Light training in your area actually last year, and it's on the website. The calendar's on the website.
Good.
I think they're doing a good job.
Thanks. Okay. I hadn't had personal things. On the next to last page, collaboration with school systems.
And she works in the school systems.
So we're meeting with the social services in the school systems and the counselors and dealing with the, and then I should know, but what's GAMHST?
The geriatric and adult mental health specialty.
And that was the one we're trying to get. We're finding that they're not they're not picking up on adult dementia as much as we'd like for them to. Is that kind of correct? I thought I read that in there. So they're trying to train doctors. That's one of the things that showed up is not real well in our survey, that they're trying to train doctors to pick up on that dementia as well. Okay. Anything else on that program evaluation? Do we want to go through?
I don't know that we have time.
Because we have, we got to do the monthly report.
We don't actually have to. It's, we didn't have any numbers that were under standard, and this committee is used to seeing the reports every month, so I don't know that we actually have to touch on that.
Well, it'd be nice if we could skip that, since we're going through a lot of stuff here. If that's okay with everybody.
Now these, like Charlie pointed out, the documents that we haven't reviewed, are the details of things that we have already reviewed, nothing new.
Exactly. The work plan are the ones that are carrying forward into next year, and we've already talked about it. With the addition of what we call standing items, it's a new requirement from external quality review that we need to have standing items reflecting all of our QI activities. The ones that we have done today were things that where we identified a need for remediation and improvement. There are certain standing items we need to have in there at all times.
So that's when they're listed under standard items.
Yeah, if you look at the first few pages of the work plan, those are the standing items that have been added. Other than that, it's all stuff we've already looked at and talked about.
When you're talking about the reading level, and you've got a QI initiative to do the reading level of, for appeals, letters to consumers and guardians, how are you determining whether they have the appropriate reading level or not?
There's a program, a software program, and you review, at the end of your letter, when you've done all your spelling and grammar checks, you can run it and it tells you the grade level. We use the Fleischman-Kincaid grade level. And when we started out on that project, they were like 12.9 grade level, and now they're 8th grade level.
I think it was actually 14 grade level.
They were 14 level when we started out?
Originally, yes.
That's how we do it.
Any explanation for this extraordinarily low
Yes.
ED utilization?
Can you tell us where it is?
Claim,
Page 8,
is this
the monthly report.
my guess is the claims lag, because that's for May, and they have 90 days to submit their claims. So you'd see how, you could say that's probably fully billed out March.
So they're not approved.
Which service are we talking about?
We'll have to wait
I
3
was
months.
looking at the emergency
Page
department
8
utilization.
on the slides for the monthly report,
Just a,
there is a big dip. I would like to think
I was
that,
getting excited.
I would like to think that Steve's and my project had already had that much of an impact.
No, so this is, because this is just claims data, right?
That would have been really exciting.
I'll put it around there. What else do we need to go over? Let me look through here real quick, see if I had some
Okay.
questions But I guess same thing, it's this that I mentioned already about working with the hospitals to benefit shared consumer information. And working on the rapid readmit and recidivist group, that's one of the issues we're trying to deal with too.
Right, and as we go along, when we do an evaluation, you'll see that's a project that is in the final stages of approval, right, Charlie? The rapid readmit is in the final stages of approval.
And then on page 17, the goal, we're talking about the detection of the management of dementia. We got in here, minimal efforts have been made on this goal. So are we working on that, or I know efforts are made, but on physician training on 3/24/15 successful, but then below we've got minimal efforts have been made. So
Yes, yeah, I think we need something there regarding what the barriers are.
So we should, I wouldn't say this was solved yet. Page 17 on the quality group.
One of the things that we've done, because we noticed little things like this, is we've made Charlie full-time QIP. So he is devoted to all quality improvement activities, goals, and projects in the organization, and that's his only job. So we have a feeling that that's really going to tighten up our process.
Yeah, these documents are a result of many people's input. There are many writers for these reports, and so one of our big goals for this year is to improve the quality of the writing that goes into the reports. And so I'm going to be doing hands-on training with the reporters regarding how to write good, effective, quality improvement items in their reports.
And so you'll be able to compare them like apples to apples instead of having, so you'll have the pertinent data in each report and in language. And I guess on that language readability, the full diagnosis is available to the client as well in full language. So we've revised it down that if somebody wants to know the specific terms, and they can get that evaluation. So provider satisfaction here on page 19, we're still well below the state average.
Yes.
And I've touched on that briefly, but I'm curious as to why. I mean, like I say, what is motivating them? Is it something Smokey's doing or something beyond our control?
I think that probably what has happened is in the past, Smokey, when we were 15 counties, got very good provider feedback. Western Highlands got very negative provider feedback. When the organizations merged, then we, of course, get all that feedback in one, which would raise one, lower the other. Unfortunately, it lowered it more than...
But, so this could be part of that transition of
Yes.
the merger, that hopefully in the next 6 months we'll keep looking at it and hopefully improve it as we instill Smokey's practices over Western Highlands.
Right. I think we're going to continue to see some negative responses because we are truly right-sizing our network. And so there are some people and providers who might lose a service, or somebody might not keep the same provider because we're right-sizing the network. But there is another provider satisfaction survey due to come out from the state in the next month. Usually they're late, actually, because usually they get the provider email addresses from us in early June. But another thing that we are doing, a lot of our providers last year said that they didn't have access to the surveys. Our database had some erroneous email addresses and contact information in them. And this year with the contracts, we've sent out a face page that requires the provider to list all their pertinent contacts. So we will have up-to-date information for what the contacts to send the surveys to.
So it might be a
hopefully
more
that'll-
accurate survey.
We'll get a
sample.
bigger sample
Yeah,
at
right.
least, I think.
How often does the Provider Advisory Council meet?
every month.
Okay.
And that's posted on Smokey's website. There are also regional collaboratives that meet anywhere from every month to every quarter.
Okay.
So there's plenty of opportunity for providers to meet.
So
What we're finding is there's very low participation
Yeah,
in those. It's extremely low, and we're really fighting to try to figure out how to increase that. In fact, that was one of the goals at our last meeting.
Okay.
Less than 10%.
Oh, yes.
Well, so that's a
Well,
little
it might
first-
be, yes, probably right around 10%. How many providers are there now? Maybe about 400 or 500?
There are 408 contracted agencies. There are 20 to 30 hospitals, and there are 80-some LIPs.
Right, so we're less than 10%.
I might add, they've been extremely CFAP friendly. I'm on it. I've missed the last 2 meetings. I need to apologize. Don't plan on leaving it, but at Dennis' point this last week when I met. But, we have.
But, so, I guess my thing is if they're really, wanting to complain, they should be coming to this advisory meeting.
Absolutely.
90% of them are turning in bad reports, and they're not even coming to the meeting to tell us what they want to see done differently.
What you're finding, this is just nothing talking, but it's a lot of the folks that are in the councils, we talk about this, is you find a lot of providers are having a very difficult time being willing to move to a managed care model versus an area program model, and they've been used to being fed information and handheld and being called up and walked through processes numerous times, and that's not the way Smokey can do business now, even if they wanted to. And providers are kind of digging their, not all, a lot are doing great, but that, you know, a lot of that 9% are digging their heels in the sand, or either burying their heads in the sand and saying, it's not gonna change, or I'm not gonna do this, and they're just gonna have.
So that could be that we're in that transition too. To
This is absolutely a transition issue. It's a big deal, but it's absolutely a transition issue.
But, I mean, somehow, we should let them know that there's a process for this, rather than just.
I mean, this is healthcare. This is not just mental health, this is everything. You know, and traditionally, if you ask providers to get together for any particular reason, unless there's some really solid, tangible benefit, they don't do it. I mean, if it's.
Well, they're competing. I mean, if we had 4 of them at our last board meeting, and I asked them that, you know, in an ideal world, they're competing against each other. So, you know, how much do they want to share their
They're
stuff?
also busy.
Yes, that's good. Yes, okay.
You know,
There's a way to compete and still help fill gaps within the network, and I think what you're gonna find, my guess is that if Smoky Rice has the network, they're gonna do so with providers that are willing to step up and fill gaps and be a part of the process versus just not.
And we do review these providers periodically as far as annually, okay. This, page 26, providers are not clear as to their first responder duties. And the goal is to ensure that providers have a clear understanding of their first responder duties for consumers in crisis. And the target date is the end of this year. That's not really funded though, is it?
Yes.
It's built into the service definition.
It is.
It's built into the service definition of the services.
For the providers. So this is something they're supposed to be doing. Whether it's uninsured, underinsured, or only Medicaid.
All providers who receive certain services, enhanced services. I mean, all consumers, sorry.
And is that true in every county in the catchment area? Okay. The performance contract supposedly did real well. Yeah, and then the providers, we've talked about that, so moving along. The IDD, is there not a waiting list?
Yes.
And then how did we take $540,000 from underutilization and move to other services without hurting, I mean, if there was a waiting list, or page 31. And I may be missing part of it. I'm just trying to understand this.
So the wait list is for Medicaid services. If somebody on the wait list has Medicaid, they generally are not eligible for state-funded services. They're eligible for Medicaid services. And most of the individuals who are in the population of individuals with IDD have Medicaid. So we did underutilize a lot of it, and a lot of this is actually residential placements, my understanding, Charlie. Residential and
we're
the,
short for residential placements. in this
well,
area.
what we're finding is that providers aren't informing us of their vacancies. So we had to move to other services because with this, and we wait till the end, you know, till the last quarter of the year to do it because we don't want to take services away from individuals who need them. But that's.
So we're working on that.
Yes, we are.
That's what they need.
The other thing is that now that there is B3 availability, then that decreases the need for state-funded services. So we're using Medicaid, and it might be appropriate to find other uses for the state-funded services.
Jumping to page 34, there needs to be more training for court officials and law enforcement. That just ties into that jail part. I mean, all the people that are in the legal system right now need to be aware of the issues of mental health.
But really, what I think for this one, we need to let especially magistrates know that mobile crisis management teams are available, and they don't just have to sign a petition unless, it's obvious, that a mobile crisis management team could come out and evaluate somebody prior to an IBC.
So it's in progress, so are y'all reaching out to all the magistrates and all the?
We are assisting providers because it's a joint effort with the providers of mobile crisis management and smoking.
And that's been a struggle because some counties only have 1 or 2 magistrates, and depending on their shift, their ability to come to that training or even be available for somebody to come out and meet with them is pretty limited. And if you talk with Ronnie Beal, he'll tell you a lot about that. There's been a lot of work around trying to train magistrates, both from the Smoky side as well as the provider side, to assist with those things.
And I do understand, we can't even get them to come to our Child Protective Services meeting because everybody's covered up these days. So I think that was my last thing in that part of the report. Anybody else have any questions on this evaluation?
Looking at this GEO team training, they're also creating their own peer support training, and I think that's a good thing. I don't know if everybody's aware of some of the things they are, involved in, but I saw them in the office of Marion working on the peer support manual and training. A lot of work has went into some of that
We put a
stuff.
lot of work into
Yeah.
that.
Well, good. Do we want to do this LME-MCO comparison?
No,
Put that off till next month?
I think we can, I just got April's data,
Okay.
so we'll review April's next month.
We'll
It's
have
not
a little
really
more
hard.
time next
There's
month.
not a meeting next month.
Oh, that's right, it's
That's
July,
the
isn't it?
August, so maybe we'll have more recent data.
So,
Quarterly reports next meeting.
so is there anything else we need to be going over or not? We've run out of time?
Do you need to vote on how this is presented to the board?
And I was wondering, I guess, am I going to be presenting this? Or
Yes,
these will
you
be- so, these list of changes, action items that we went through, do you think I need to list those off? And I didn't make notes about them. Or just say that the committee feels that we've addressed most of these issues and that or
You have 5 minutes.
Throw in the auctioneer hat.
I guess if you think that we are adequately covering our functions and improving the items that we need to based on this plan, that you could, that if this committee approves it, we need to have this committee vote
Right.
to approve it and then recommend that to the board as a whole.
So I guess we will need a motion to approve this program, but do we want to have any changes or do we feel like
Well, we're not going to practice scare care coordination.
But I'm just wondering if we can leave that to the staff or if we need to itemize that in the
I
board
don't think
meeting.
you need to.
So I'm comfortable with the answers I've gotten to my questions, and I feel comfortable with that. Like I say, I'm so underqualified compared to all y'all, but I'm trying.
The one thing I would just like to know, again, from the staff members, is there anything in the report that you feel like would raise, is either controversial or needs to be pointed out specifically?
I don't think so. I think one thing we talked about was provider satisfaction. I think that's going to be kind of a big thing because we look bad compared to other MCOs across the state. But everybody knows this.
Yeah.
Not a secret.
I think that's what I would, in your report, the relevant issues at the governance level of the board is pointing out the areas that need to be closely monitored, and that may be one of them.
Maybe provider.
A brief explanation of that. I don't know if there's anything else that would be particularly important for the government.
The access to care QIPs, because there is a measurement for that. Now, in the last quarter, they said that we met the criteria. We don't actually get the numbers anymore, they just tell us if we met it. But it's been a standing item on our program
Right.
improvement grid, and there are two, right? One current project and one in development to address this, so it's being adequately addressed.
I would probably still mention it though.
Yes.
I mean,
No, I mentioned it, that it exists and that was
So
being
access to
addressed.
care and provider satisfaction, and
Yes.
then the access to care has a current and a developing project
Yes.
going on. So, anything else that anybody on the committee wants me to mention to the full board about this report? And do I have a motion to accept it and present it to the board? All in favor? And I didn't say any discussion, but we've been discussing it.
So let me just, I mean, this is obviously a tremendous amount of work. I mean, you know this data really well. I just would say it at the board level, the governance level, and ultimately that initially rests here with this committee. Looking at quality data, understanding quality data is part of the responsibility of a healthcare board. Because of the quantity of information in here, we're relying on you to point the areas out that we should be attentive. And we can go through like we did just now, bit by bit, but in reality, you know this data inside and out, and we really rely on you saying, here are, at any of these committee meetings, here are the 3 things that we feel like you must look at today, and this is information that needs to be really fully understood as we move forward. And you have always done that well.
Thank you, I think this is our,
Right.
what we developed to use internally, and we decided to be very transparent and share it with you, so it's kind of our dirty laundry list.
Yeah. I mean, that you
And
have
I
to.
like it because it shows
Yeah,
where you're
yeah.
at on it. And I echo his sentiments. Thank you all so much for all the hard work. I do realize this is a lot of work has gone into this. And it's a constantly changing program because y'all are working on it as we do. So thank y'all.
And thank you, Charlie, because you brought our quality improvement committee a long way.
And I'll mention that quality data and sampling as well as one of the 3 things when I present it to you that we're working towards, just to have better quantitative information. So.
Oh, for the state surveys, yeah, that the state surveys, yeah, they don't use samples that have a very good confidence rating.
And do I get a movement to adjourn?
So
Second.
All in favor?
Aye.
Thank you all so much.